This is the Florida Foot and Ankle Society again. And so basically today we are going to be speaking about some challenging, interesting patient case studies with question and answer sessions. We are going to try to get through each case that each of the programs listed below has graciously volunteered to share. The format of this is going to be each fellowship or their fellow or the director will present a case with some background information on a patient, about 5 or 7 minutes per case. We're going to try to keep it quick. Speakers may ask questions along the way. Please use the chat area so that the moderator or myself can propose these to the speaker. And we may pimp each fellowship director or some of them at the end to comment on any observations or things that we've picked up along the way or comments. So that's kind of the format tonight. I think it should be exciting, and we're going to try to make it quick and informative and exciting. So just because I'm moderating to start with, I'm going to ask my current fellow, Dr. Daniel Perez, to give us our first case study. Dr. Perez, are you on the line?
I am. Can you hear me?
Okay, take it away. Take it away.
All right, great. Hi, everybody. I hope everyone's doing well. I'm Danny Perez. I work with Dr. Bellis over at the Orthopedic Center of Florida down in Fort Myers. And like he said, I'm going to be going over a case for a reconstruction of a failed first MPJ hemi implant arthroplasty.
Sorry, that's me. Gary, go.
That's okay. All right, so we have a pretty elderly female here who had previously gone a first MPJ hemi implant arthroplasty. On the x-rays, we can obviously see that there was a previous distal first metatarsal osteotomy, and our x-rays also show some subsidence and failure of this metallic hemiphalangeal implant. Just a little background information on hemi implants. There was a great study published in 2007 from JBJS that reported about a 24% failure rate in an MPJ hemi implant arthroplasty. Although this number, I think, is significantly improved in recent years due to patient selection. However, I think more long-term multi-center studies need to be published to really kind of evaluate that data. Nonetheless, we'll continue on to our clinical evaluation of this patient. So here we obviously see that the great toe is elevated from the ground. The first ray is significantly shortened, which is of concern for revision because at this point we're obviously considering a fusion for this failure, and we're anticipating further loss of bone, which would result in worsening of the shortness of the ray and possible overload and instability of the lesser MPJs. When this patient first presented to our office, her main complaints were really that the toe was not purchasing the ground and not functional for her, in addition to painful, pain noticed in her shoes. So we booked this patient for this hardware removal, allograft bone block arthrodesis. Alternatively, we could have considered an autograft harvest, but due to her age, we wanted to avoid any additional surgical site morbidity. So we'll go on to some intraoperative images here. Here we have obviously removed our implant and began prepping our joint surfaces. We use a pin distractor to gain adequate visualization of our joints, and we really emphasize aggressive bone preparation here, with subchondral drilling and fenestration, even at the expense of additional shortening, because as we said, this is a revision and salvage attempt, and ideally it should be the last of such efforts. So you can see we use this pin distractor, and prior to even implanting our graft, we use it to distract the skin and blood vessels somewhat in preparation for this acute lengthening that we're planning. So the next slide is going to show us, intraoperatively what we're measuring, our trial sizer to become the appropriate length to restore our first ray. On the right, you can see that the yellow arrow is pointing to this sort of anatomic specific allograft, and at this point it's obviously already been implanted, but Dr. Bellis and I are working on some research, and our technique has typically been to obtain around 20 to 30 mLs of bone marrow aspirate from the tibia, typically the proximal tibia, using a jam sheeting needle and about a 60 cc syringe. And once this allograft is appropriately sized, we would then allow it to soak in this bone marrow aspirate for approximately 5, sometimes 10 minutes. We'll be looking, more closely into this data, but anecdotally speaking, we have seen pretty good to, actually excellent absorption and penetration of the graft with this amount of time. So the next slide, we're going to talk about just some of the materials we use, but typically for something such an acute lengthening, a 10 mm graft is historically what's recommended for such a repair, but obviously you can see that I don't think that would have been sufficient in this case and for this patient. So we opted to obviously go with double that size, which was a 20 mm long allograft. And, this is obviously an aggressive lengthening for such an acute process, but we would caution you to make sure preoperatively that the circulation of the toes and the foot is capable of handling such an acute lengthening by taking preoperative, non-invasive vascular studies, including ABIs and TBIs. Here are some of the final intraoperative images of the graft in the fusion site, which is maintained with a robust reconstructive first NTP plate. If you look at the second most proximal screw, I think we would notice it's a little bit long. However, these are not the final images, but the second to final. This was actually removed and replaced prior to closure. And at 1 month follow-up, we can see that there's really good signs of healing and graft incorporation on this next slide here. Things seem to be going well. At 2 month follow-up, again, things seem to be going well. And then we do have, luckily, some 5 to 6 month follow-up x-rays, and pretty much we're showing excellent maintenance of the correction and graft incorporation, and really no signs of failure. And we've had quite a bit of patients that have presented to our office similar to this patient presentation. And, one of the pitfalls that, I've kind of come to find in these type of repairs is that in this case, it seems that there was adequate real estate on that proximal phalanx to get like 2 to 3 screws in there. But, I was wondering if any of the fellowship directors had any thoughts on alternative forms of fixation for something like this, because recently we had a patient who had poor bone quality of that proximal phalanx, especially once it was prepped, and we really struggled to get adequate fixation on that phalanx. And Dr. Bellis and I, we decided to add an additional pin for stabilization. So I don't know, that's just a point I'd like to bring up, and maybe a topic of discussion in the Q&A. But finally, at the last slide, we can see the post-operative progression clinically of the incision site. And obviously, one of the major pitfalls of such an aggressive correction is the incision healing and tissue necrosis. Initially, we can see some skin irritation and a little bit of medial incision site necrosis, but obviously at the final follow-up, we see complete resolution and minimal scar formation. So I think it's just really important to know that during the procedure, minimal subcutaneous dissection should be performed. And once we identify that EHL tendon, to really do full thickness dissection and aggressive debridement of anything that's concerning or non-viable. So thank you, and appreciate your time.
Thank you. Yeah, a couple of points on my end just to add to that. In regard to the graft, notice that when you're using such a large graft, we do try to stabilize it at least with 1 screw, just so it doesn't piston or pivot. It doesn't have to be necessarily a locking screw, but something to just kind of help give it a little bit of added stability, even though it does fit in there pretty nicely with that cup and comb reaming system. I think the biggest pitfall with these is just to kind of warn patients about that they most likely will have a potential for wound, and that it's usually superficial wound care that you might have to give. So I would ask the other fellowship directors any questions or comments, something you would have done better, different. Anybody from the there's a chat question here. Post-op protocol. Doc, do you want to take that? Dr. Perez?
Yeah, so great question. I think typically what we're doing for primary first FPJ fusions is pretty much weight bearing as tolerated pretty early on. I'd say almost right away, although the first kind of week or two, I prefer them to take it easy and do a little more heel touch in a cam boot as opposed to full weight bearing in a cam boot. But with that said, in a case like this, I'm a little more cautious, and I've been keeping them off the foot for about 6 weeks. But around 6 weeks, I'm letting them kind of touch down in a cam boot. So Dr. Bellis, I don't know if you had done anything differently prior to my arrival.
Yeah, I think the biggest thing is when you start to see some bone consolidation, you can do a little bit more weight bearing, and that's going to be different depending on the size of the graft and the patient's heal rates. With all of these, I also recommend supplementation with vitamins. Make sure that nutritionally they're up to date, and I always vitamin D these patients just prophylactically. I don't get the D workup, but I definitely just put them on something to supplement their bone healing: calcium, D, zinc, and magnesium. We have another question, Dr. Perler. What was your preoperative workup? Were you worried about a residual infection as a reason for the implant failure? So I'll answer that one. This patient never had a history of an infection with this implant. There was never a cellulitis. What I usually do is ask them if there was any kind of infection or if they were put on any antibiotics post-operatively. I find these are mostly functional failures as opposed to infectious failures. There was absolutely no sign of infection in that first picture. You can see that. And, certainly if there was any history of that, I would have done a workup, sed rate, maybe do a scan of some sorts, like a white blood cell scan. But again, clinically and historically, there was no infection risk there. So that's really depends on the symptoms. Second, was there another question? Was there a use of a bone stimulator in a post-op course? Would there be a time where you would consider to do this? So yeah, usually bone stims are hard to get approved, and you'd have to document that there's a non-union or a fracture, not or a delayed fracture. Since there was none of those, getting these covered is difficult. And post-operatively, if we did see a delayed healing, that would have been something we would have implemented. But I found that, and I think Danny can attest, is that since we've been using a little bit more of the bone marrow aspirate, we found less and less issues with that. With delayed healing.
I have a question, Andrew. Did you guys use a tourniquet on this case or no?
I believe we did use a tourniquet.
Yeah,
just to assist.
Yeah, we've been using tourniquets on these.
Yeah, I think for me, tourniquets are helpful because otherwise, the biggest problem when you do these is you stretch out the tissue so much that you don't have any. You don't have the soft tissue envelope is if it starts swelling, you have very hard time closing over these plates because some of these plates are reconstruction plates and they're larger and they're hard to get covered. So one of the things, Danny, I don't know if you mentioned it or not, but when we do these incisions, we try to go like really full thickness. We try not to layer this a million times. We try to go keep these full thickness flaps, because if those engorge and swell, it's going to be a hard time closing it. So it's a small risk we take with becoming small ischemia from the tourniquet, but I think we've done okay so far.
Because that's always been my concern in these cases. I mean, I think it looks great. I mean, you posed the question earlier if there was any other way to fixate it bone wise. I don't think so. I think the fixation is perfect. I'm always real careful with these cases in regard to the perfusion of the tissue, particularly at a 1 centimeter graft size. So I do order some vascular studies pre-op on these patients, because the worst thing is to have a black toe in 2 or 3 days after doing it. So
yeah, we usually
get real careful with that.
Yeah, TBIs on all these.
Yeah.
Sometimes if the hardware is too prominent, you may have to change it to a smaller hardware, and then you might need a pin down the pipe to help give you added stability.
Yep.
Any other questions or critics?
In the chat, I think Dr. Cottam asked about any autograft using this. And to answer your question, in this particular case, we did not. Other than the bone marrow aspirate. I think we do have quite a bit of patients, at least from my chart reviews of Dr. Bellis's practice, that there were some, I think Dr. Bellis, correct me if I'm wrong, we used like some calcaneal cortical and cancellous grafting, as well as tibial autografting for these types of repairs in the past.
Yeah, so that's a great question, and that's kind of how my practice has evolved over time. I used to take structural grafts, whether it's distal tibia. Originally, I was doing posterior calcaneus, they were just not robust enough. And then I started going distal tibia, and I would take a nice wedge out and then backfill it with allograft. And those were doing good. But then since switching over to this bone marrow aspirate and the customizable, or the at least the anatomically contoured allografts, we get the best of both worlds, some structural allograft plus the BMA, which gives us the growth factors. And I've had some excellent success starting with this. And this is just one example of us pushing the limits to the 20. We've done this several times now with good success. So I think the reason why I bring this case up is just to show you that, you know, you don't have to be, I mean, you have to be careful, but you can push the envelope if need be, as long as all the other biology makes sense. Okay. All right, good. Thank you, everybody. And thanks, Dr. Perez. Okay, next up is Dr. Cottom and Dr. Wolf, who will be giving our lecture today.
I'll be giving it. This is Joe Wolf. Do you have our presentation on here, or are we going to be running it on our end?
I have it on here. I've included it. Could you just give me a next mark and I will go to your next slide? Would that be okay? Or did you update your?
Nope, that's perfect. Yeah, you can go on to the next slide.
Okay.
All right, so this is a case of ours. This is a 75-year-old male, came into our clinic. He's got that stage 4 posterior tibial tendon dysfunction, adult acquired flat foot. Right now for this one, we're really looking at his right side. That's the most problematic for him. As you see noted there, he's also got some ankle arthritis. His past medical history is pretty unremarkable. He's 75 years old. The extent of his activity, he likes to play a little pickleball every now and again.
How's it going? Good. I'm just checking in for 2 nights.
Hey guys, if you're not lecturing, please mute yourself.
So we'll be valet only?
Yeah.
Sorry, go ahead.
You're good. You're good. Yeah, otherwise unremarkable, non-smoker. If you can click through again, I think it should animate, yep, into some further x-rays. So there's a lateral, and then if you click again, and then one more click and some lines should start to show up. Perfect. So there's kind of the background information on this guy, and we kind of want to get this a little bit interactive, if you will, and kind of start reaching out to some of the fellows and seeing what you guys are thinking. So we can start right off the top. Dan just presented for you guys over there on a stage 4 flat foot. What are you guys usually looking at doing?
Any of the fellows you want to speak up?
So yeah, hey, Dan over here. For stage 4, I mean, obviously I'd work it up by getting a CT scan, see what we're looking at, even maybe consider, an MRI, but I would assume that PT is shot and all those medial soft tissue structures are shot. So, I mean, I think we'd go probably with a triple and see if we can not realign our hind foot under the ankle joint and see what our ankle joint is looking at that point.
So this patient's complaining of both foot pain and his ankle is the main problem. It's extremely painful with activities.
Any other fellows? Hello.
So in West Palm, what would you guys do with this guy? You can see the foot structure here, painful ankle.
Yeah, so James,
Brad, is your fellow on, Brad, or just you?
yeah, I'm not sure he's on yet or not. But yeah, well, I think
let's go to any other fellows on. We want to kind of.
Yeah, we're here at Westside. This is Tarek. Yeah, cool. I mean, just looking at this as well, and obviously you would consider obviously a triple, but again the CT, and you said the patient also had ankle pain as well.
His main complaint's his ankle.
Just completely ankle, correct?
Ipsilateral total knee.
Yeah, I mean, You can consider obviously TAR, medial column fusion, a calc slide.
So you would do a TIR calc slide and a medial column fusion?
Or a double TN fusion.
Okay. Any other fellows? We're just trying to kind of see what the other programs.
All
are.
right. All right, gave it away.
All right. You can
Brad,
click
go
on.
ahead.
Brad, what do you think?
Well, I think, James is, correct in that, where is the pain? Is it subtalar joint arthritis pain? Is it ankle joint arthritis pain? Is it midfoot? Is it all the above? Because the alignment's not terrible. Of course, the heel is lateral to the tibia, but, it's not, doesn't look like a lot of valgus or varus kind of thing. Definitely a flat foot. So I think, finding out where the, because you can do a triple and then the ankle is a problem, or you can do an ankle replacement, then the subtalar is a problem. You know what I mean? So you don't want to get into that. So I think Dr. Cottom is correct in that, doing that clinical exam, your diagnostic injections, doing your MRI to see which joint is the most problematic or which ones are, is essential.
Brad, what would you guys do then, Brad, with, you got the guy walks in like this, 75, you did your workup with him. You can see his foot's pretty much shot. It's flat. His ankle's bone on bone. He's got a knee on that side. What's your plan, I guess, is what we're trying to.
No, I got you. I think that, if you're going to do any kind of ankle preservation, like an ankle replacement, which, you could shoot for, you got to fix the foot as well. So you could either do your, triple and fix the foot and then come back and do the ankle replacement, or kind of do it all at once. Those are the options. Or you just do a pantalar and be done with it. If you think, it's not something you want to get too involved with, doing an ankle replacement or that sort of thing.
So you guys okay with doing pantalars on patients with total knees? You worry about the knee, the pressure on the knee, or?
No, it's a good question, but I think the sagittal plane deformity is most problematic for knee replacements. My previous fellow and I, Jake Wines, we published an article showing that, really the subtalar joint frontal plane fusions that aren't fused correctly, or even if they are fused, puts more stress on the knee. So, this valgus that he has, even though it's more translational valgus, not really, heel valgus, the heel's very much lateral to the tibia. And so that's problematic for his knee. Yeah. But you're right. Yeah. You stiffen up the foot, it puts more stress on the knee. But I think if you stiffen up the foot and put the heel under the tibia, it's less of a concern. The ankle, sagittal plane, I'm not so worried about with the knee, is what I'm saying.
Gotcha.
I was going to chime in. My fellow's not on tonight because she's doing the Zoom room moderation. But this is a case, aside from the fact that, we'd work it up with a CT scan and MRI to better understand the tibialis posterior tendon. I think, tib post reconstruction is going to work. So I think this patient's probably going to need a triple arthrodesis. And I'm not a huge fan of pantalars if we can avoid them, especially when somebody has bilateral disease and proximal knee replacements or joint replacements. So to me, this would be kind of a staged approach to a total ankle, but you got to get the foot corrected before you go to that route.
Yeah, I think I agree. And I also think that, theoretically, if you stage them and you get that foot centered underneath the ankle, I've seen the ankle pain get better. And granted, it may not be a permanent solution, but I've seen it happen. But certainly, yeah, I think you're teeing them up for an ankle replacement if most of the pain is coming from the ankle.
All right, Dr. Wolf.
Awesome. Yeah, thank you guys. So you can click through to the next slide. All right, so that's kind of what came out there in the end is what we went through with this. So we staged this guy, did a triple on him first. As you can see there, you can click to the next slide. And then brought him back about 3 weeks later, once his swelling was subsided, and put the total ankle in him. And those are his post-op x-rays. We actually, if you click again, there you go, some further out. Also ended up going back because you saw originally on his x-rays had a similar thing going on the left side. Went back and did the left, same thing on him as well. And he's off doing great now.
What incisions did you guys use for your triple? And then why 3 weeks and not longer or sooner? What was your deciding factor there?
So when I'm doing a staged procedure, like a triple on this, the biggest thing is that medial incision for the TN fusion. So I really bring that down medially when we do that, because we don't want to interfere with that anterior incision for the ankle replacement. And I talk to a lot of my patients about staging these things. We can either stage them and let them completely heal up and consolidate and go through that whole healing process after a triple, and then coming back to an ankle replacement, which they get to go through basically the same thing again. Or we space them out 2 to 3 weeks apart just to let the soft tissue swelling calm down. And I've been doing the 2 to 3 weeks apart for the last 7, 8 years or so. And so far, knock on wood, haven't had any major issues with that. But the patients like it as well too. It's like all one big healing process with that. But you definitely need to space out your incisions, especially that medial and anterior one, so you don't get any dehiscence. And we've experienced that before. So, you know, you learn these things as you go on. So, but that's the biggest takeaway from that. And this picture 6 weeks out. We've got films on him 3 years out with this same implant on this right side. And then there you go. So he's out 3 years, and he was happy enough, or we went back and as Joe will show you here on the next slide, we wound up doing same thing on the other side just last fall. So
do you plan your fixation for your triple any different when you're planning on doing a ankle replacement?
Yeah, you got to be careful what ankle system you're using, just based on the tailor preparation, where pegs and fixation is going to be. So I try to really, I talk to my fellows, and Dr. Wolf knows this well. You got to plan where you're putting those screws, or else last thing you want to do is be in your second stage surgery and you're trying to impact your talus and you're hitting screws and things like that. So we just take our little time up when we're doing the triple and make sure we try to get everything lined up pretty well and go from there.
When you stage them like this, do you have, I'm sorry, Adam, when you stage them like this, do you notice, because you're having to immobilize them further for your triple, that the ankle gets stiffer as a result?
No, because after we do the ankle, it's basically ankle joint replacement protocol for us. So, you know, we actually allows the triple to heal up a little bit more. But after the ankle's put in, it's the same basic regimen with that. And, you know, I know literature, and we go to the national meetings where people are saying how quick they walk these people, but you know, we're probably keeping these people off this from the initial procedure before I let them bear any weight on it. It's close to 6 weeks usually at minimum, and just because of incision issues, that's why. So I'd rather protect the soft tissues than get them moving right away. I'll let therapy move them.
Great.
Would you ever consider doing this not stage? Would you ever consider doing it all in one procedure?
No.
No.
I think it's too much work, too much swelling, too many problems. That's just I think if you get away with it and it turns out well, that's great. If it goes downhill, it's a recipe for disaster for you and everybody involved. So we want to do this as safe as possible.
Do you use tourniquet when you put your ankle up?
Oh yeah. Yep.
Okay.
With a thigh. Yep.
Any other questions?
Do you ever find that after the triple, some patients don't really want to proceed with the total ankle anymore?
So like Andrew said earlier, I've had some patients way back where we've, talked about staging things, and, I've got some patients where we'll stage them, like I said, 2 to 3 weeks apart. So it's all one big process. And I also have some where they want to try the triple first and then see how the ankle does. And if we need to do it down the road, we'll do the ankle. And you know what? Some people, even though their ankle joint shot, they do great with just a triple and they don't have pain in the ankle. And if they're not having, if it ain't broken, don't fix it. So we leave them at that. So.
Do you use popliteal blocks with your total ankles?
We've stopped doing that up in Sarasota about 5 or 6 years ago. And it's the only reason being is I've had the anesthesiologists do the blocks, and we've had some nerve irritation. And as you guys all know, the patients come to see you after surgery, not the anesthesiologist. So I had a couple really unhappy patients, even though I had no part of that part of the procedure, but I ordered it. So we do a lot of local now, and we keep them in overnight, and we keep them comfortable, and it's been fine for a number of years. So.
Okay. Any other questions, or that was great. Thank you, Dr. Cottom. Okay, next is Dr. Lamb. Take it away.
All right, great. Good evening, everybody. I have a kind of a deformity case to present, kind of a bilateral lower extremity deformity case. Can you go to the next slide, Andrew? So this is a 61-year-old female who has a history of spina bifida, presents complaining of ankle pain and limb length discrepancy. Her deformity on the right is she has valgus, internal tibial torsion, and a prior TTC fusion somewhere else that was performed. And on the left, she's got leg length discrepancy and tibial valgus. So next slide. So here's how she presents. You can see the mechanical axis of the lower extremity, center of the hip to center of the ankle, should pass through the center of the knee, and it does not. So it's lateral to the center of the knee, indicating valgus of the both lower extremities. You have to do further deformity analysis to see if it's tibia or femur that's creating that valgus, but you can see the valgus. I think this points out the importance, and Jamie had mentioned this earlier in his case, that you got to look above, the foot and ankle and make sure you're, looking at the entire patient, because your foot and ankle surgery can fail because you're not looking proximal, or it can be creating more problems proximal, as was stated earlier. So this is just the hindfoot alignment view. You can see that on the previously fused side, still looks like there's maybe a little bit of varus of the hindfoot, but in general, pretty straight. But you can see the torsion, you see the internal tibial torsion on that right side. Next slide. So here's just a little example of how do you determine leg length discrepancy. And so, of course, we can measure clinically, but the most beneficial objective measure is to look at these long leg x-rays or erect leg x-rays. And if you look at the hip here on this particular patient, they're 5 millimeters shorter on the left side, the non-operated side. And on the right side, you can see that they have a 2 centimeter at the bottom. It's on a 2 centimeter block. So the patient stands on a block to try to feel like their hips are equal. And then we indicate that on the x-ray. So 2 centimeters minus the 5 millimeters, then you get 1.5 centimeters of leg length discrepancy. So this is how you can measure it. And I thought it would be important for the fellows and residents to see this so that they understand, this is, kind of the best objective way to measure this. And usually the hips down, if they have a previous pelvic osteotomy or some sort of pelvic dysplasia, you may need to use the hips, meaning the pelvic measurement to the ankle, but in this case, we just use the femur because there's no previous pelvic surgery. So you can see the leg length difference. Next slide, Andrew. And so if we do our core analysis and look for our proximal distal axis lines, you can see that on this previously operated on foot, leg and foot, you can see that there's a proximal tibial valgus deformity. We look at the lateral, the foot is plantar to the tibia, so that's important. You see the previous hardware. So there's your proximal tibial valgus deformity, and you have the rotation deformity on this side as well. Next slide. And also some, you can see some foot deformity as well with this spina bifida patient, that she was also complaining of some of her bunion and hammer toes, which were also a concern for her. Next slide. So I just, for this, the right side here, here's where the core is at the level where I put my wire across on a C-arm shot. I was going to remove the hardware and do an osteotomy. That's the plan. Next slide. So here's the level of the ankle. I'm basically put a wire in here. So this is on the left side, it's a wire. On the right side, it's the lateral of the wire. You can see anterior to the nail, because when you do these derotation osteotomies of the tibia and angular corrections, I use a temporarily placed external fixation device, so a 2-pin construct. So I'm going to put a half pin right here where my wire is. That's what I'm going to do. Next slide. Put my half pin in there. Distally, you can see I put a half pin in proximally, and then I hook up a external, a monolateral device to be able to hold my tibia once I do my osteotomy. So those are my 2 half pins, and then I remove my previous rod that was in there, and I'm going to exchange rods. So I'm going to take this rod out and put a new one in. The level of the osteotomy is indicated by my wire right there at the right screen. Next slide. So then I'll do my osteotomy. You can see multiple drill holes in the tibia, and then the osteotomes, one kind of anterior to posterior, one medial to lateral, creating the osteotomy. Next slide. You definitely don't want to use a saw here. You got to use low energy. And then you can see I placed the rod in from the retrograde nail from the heel up across my osteotomy. I used you can see the change in the angle of the half pin. So that's, correcting that the valgus deformity. And then I locked my nail above the osteotomy, and now I'm putting in what's called a blocking screw. You don't want that windshield wiper or side-to-side effect of the nail, because that can create, more valgus deformity. So we want to block that valgus deformity. So next slide. So put in a blocking screw there. You can see it on the right-hand side of the screen. That's my external fixation pin. You can see that I moved, and then I did derotation and angulation. So both planes of correction. Next. And then also did some correction of her toe deformities. And there she is kind of post-operatively. Next slide. And then kind of further down the road, she was, weight bearing. Weight bearing is tolerated in a surgical, like a walking cast. And then we changed her to a boot. But she definitely was only partially weight bearing. So this nail was kind of custom length made to achieve this correction to cross the osteotomy site, because it is a longer than normal hindfoot fusion nail. So that was, and you can see on the next slide, Andrew, I think I have further healing here. You can see nice calcification or regeneration of the osteotomy. And then next slide, Andrew. And then I'm just showing you the MAD, the mechanical axis deviations. Now it's through the center of the knee, and correct the rotation and the angulation. And then now we're on to the next slide. Andrew, which is just a rehash that now we have the left side, which is shorter. So we have to lengthen the left side, but we have the same deformity, the valgus. Next slide. So I think it's the left leg surgery here. So now here's a recap. Here's her left side, short and tibial valgus, just like before. So in this case, you can pick the nail or you can pick an external fixation device. There are self-lengthening magnetic nails that you can use, but in this case, the ankle is without harm. She doesn't have ankle issues, so we can't cross the ankle. So it'd be a top-down nail if you were going to do it. So I decided X-Fix for her because she and I discussed options. So next slide, Andrew. So this is just a slideshow showing the osteotomy of the fibula, placing the external fixation proximal tibia. Next slide, Andrew. So this is the proximal ring. Next. This is the osteotomy showing, completion. Next slide. The distal frame being mounted. This is a 6-axis correction device, so computer program to program in the rotation, the length, and angulation. Next slide. Oh, go back one, Andrew. So this is the Boby test. You see that line through the center of the ankle, center of the knee. So this is just showing that you can do that intraoperatively, where you scan the fluoro up and down the leg to ensure proper alignment. So if you want to do like an acute correction of the limb, you can do it that way. Some docs, some of my partners use a grid on the table where they put it underneath the leg, and it's a grid system, which then you can see it on your fluoro machine. So those are two options there. Next. So just completion of the osteotomy. Next. So this is post-operatively, immediate post-op, and then we program the computer to get the leg straight, as you see there. Go ahead. And then got the tibia corrected, the valgus, and the length. Next. And then remove the external fixation device. So she was weight bearing as tolerated right after surgery. I did do a common perineal nerve decompression at the neck of the fibula at that time of surgery as well, because you're rotating, lengthening. And then you can see we got the tibia straight on that left side. Next. And so this was just showing kind of the bilateral tibias here. Next. And then this is kind of the progression showing the overall alignment of the both tibias. And then this is just the final clinical.
That's great. A couple questions, Brad, if you have one more second. I think we have one from Jamie. What length nail? You said it was a custom nail. Are those something you have to order ahead of time, or are they just are those custom made? And what's the post-op protocol for that long nail that you did? And then also the post-op protocol for your X-Fix.
Yeah, so post-op protocol for the nail on the right was, like I said, kind of protected, partial weight bearing with the walker and walking cast at first for about 6 weeks. But with that axial nail, you could walk right away, on the tibia. So that's the beauty of just a tibial osteotomy only. But she did have some foot procedures, so that's why I did partial weight bearing. And then the weight bearing protocol with the frame is on the left side was just weight bearing is tolerated. No surgical shoe. I think she did have a surgical shoe because she had some foot procedures done on that foot at the same time as the tibia. But weight bearing is tolerated. And yes, the nail is custom made. Some companies make them longer. You can get them off the shelf. Some companies you have to make custom made. But it is a hindfoot fusion nail. I have used tibial nails or femoral nails on occasion in the old days, but now you can get some, custom made hindfoot fusion nails. And so that's what I use there.
And then how long do these cases take? And what was the timing between the two cases?
Yeah, so I mean, 2-3 hour surgeries for each of them. Just it depends on kind of how much soft tissue. Like I said, I did a nerve decompression, and then with the removal of the nail and then exchange of the nail, that does take some time. So maybe a 3 hour case, something like that for each of them. And then timing between, yeah, usually I wait a good 3 months between to do the other side. And then with her, I waited longer because with spina bifida, sometimes the healing's a bit slower for sure. So I gave her probably 6 months between treatment times till I did the other side.
I think the last question in the chat was choosing acute correction versus gradual on one side versus the other.
Yeah, so I think that, and same in your case, Andrew, do you acutely lengthen that first metatarsal, or do you do a gradual lengthening? I think that's kind of, surgeon preference or choice in some respects. In any acute lengthening, you got to be mindful of the nerves and the blood vessels, as you pointed out in your case. Same here. And even in gradual correction, you got to be mindful of, like I said, I did a nerve decompression just because I'm concerned that, the added, 1.5 centimeters of length and the rotation angulation can create, entrapment or stretch on your nerves. So, I think that it definitely is something to consider. But you'd have to do a top-down nail, so I'd have to get one of my partners involved for acute correction on that left side. So that would be a consideration for that. And then also X-Fix is something that she was not opposed to, and we discussed kind of the positives of that. And she did take a while. I think she was in that external fixator for about 4 months, maybe 4.5 months, till that 1.5 centimeter of regenerate bone fully healed. So that was took her quite a while. So that is also a consideration. With kind of you can. I'm confident letting her weight bear with the frame on, even during that longer consolidation period.
Great. Well, thank you. That was a great case.
Thank you.
Okay, next, thank you. Next, we have Dr. Tarek Amin and Dr. Warren Windrum. I think Tarek is going to be speaking, or I could be wrong.
Yeah, no, I'm here. I'll be speaking.
Great. Thank you, Tarek.
Yeah, so starting off, like I said, this is a case where we'll talk about an Achilles tendon injury and a revision. So kind of to give a starting point on this case is we had a 41-year-old female, pretty much healthy, no past medical history, no known allergies, but previously in June 22nd of 2021, she underwent a Achilles tendon sleeve injury, like an avulsion injury. And obviously that was before I started the fellowship, but at that point, the patient was repaired with a suture anchor into the calcaneus and a 3/0 headless screw to fixate it, and was in the post-operative period. And that's when I started the fellowship. And kind of this is where we started off is on August 20th in 2021, during her post-op period, she was walking around, she was unprotected on her right leg, and without a cam boot on her knee scooter, and fell. So upon impact of the fall, she caused an open laceration with a rupture of her Achilles tendon on the posterior aspect and transverse fascian behind the leg, and also underwent displaced calcaneal fracture. So in Broward County, she was seen at another hospital. She went for some reason and had a debridement and primary closure, but then followed up back with us 4 days later and was admitted to our hospital for revision and definitive repair. Let me go to the next slide. So this is what was seen and what was taken upon the injury that happened. The patient showed it to us, that you can see the transverse protrusion of the re-rupture. Obviously, the initial surgical repair that was done was healed, and that was a vertical incision, so no issue with that. But obviously, when a patient sustained this kind of injury on exam, you're going to expect obviously no plantar flexion. Your concerns are you have an open wound and a significant pain to the posterior ankle. So the basic workup is obviously we have our x-rays, but getting your MRI is really key in this portion. And what we appreciated, obviously, from the pre-op x-rays is you can kind of see that the 3/0 headless screw that was inserted initially to hold one of the fragments had nothing to do with the Achilles tendon repair, was intact, but you can see some avulsion or cortical bone that avulsed with a retracted, coiled up Achilles tendon. And on the MRI, you can more appreciate the footprint of the peak suture anchor as well, and kind of take more notice at the amount of inflammation and bone edema at the posterior aspect of the Achilles, the calcaneus, and where the Achilles tendon would initially insert. So going to the next slide. These were operative considerations, and it is, you know, if you go through some of the literature, Achilles sleeve avulsion injuries aren't predominantly the most common Achilles tendon injuries you find. There really is no algorithm for you to follow, or no, like, you know, textbook cookie cutter kind of thing, or this is what we do. So you kind of have to go into these cases with considerations of what your MRI obviously tells you, but your intraoperative workup. And I'll kind of explain with these techniques why and which one we did choose and which one we didn't. So you can consider a speed bridge with arthrex or reapproximation, but you have to appreciate that you have to have adequate bone stock of the calcaneus and enough tendon to even reapproximate it, and without having to go through, you know, obviously lengthening procedures for your tendon and whatnot. Transosseous bone tunnels with sutures are obviously an option. There's an article by Yang et al. That was released in one of the orthopedic journals, and he talked about it with three of them, making 3 tunnels. But you also have modified suture anchors with a crack out. Obviously, if you have adequate bone stock, that's something you would want to do. You really have to worry about that posterior calcaneal edema and softer bone, I guess, to that extent. If you encounter that, screw fixation with the washer and then tensioning sutures is one thing. An FHL transfer with, you know, I'm not sure what kind of fixation some of the doctors use, but, you know, obviously you have suture butt and you have transosseous screws, interference screws. Going to the next slide. So this was our plan. So we open up the patient, and obviously when we go to the next slide, you'll see it better. But intraop right now, we opened up, and we appreciated really poor bone stock with a lot of edema at the superior aspect of the calcaneal tuberosity, where we also saw an avulsion. It was almost like a avulsion fracture of the calcaneus. Whenever we took out the peak anchor, it kind of left a hollowed out area, and all the edema made it very, very difficult to just leave it alone. We had to address it at some point. So the next step was we had to look at the Achilles tendon and look if we had adequate substance, and we did. So what our plan was at that point is we did a crack out stitch around the periphery of the proximal substance of the Achilles tendon where it avulsed from the insertion, and then we did a central whip stitch with fiber tape. And after doing all that, we were like, let's make dorsal plantar transosseous tunnels medially and laterally around the posterior aspect of the calc. Use, you know, 1.5 millimeter with the K wires and made those holes, and we used the suture lassos to grab those proximal crack out sutures individually on the medial and lateral aspect of the calc, brought them down, tied them off, and we had to address the fact that after this re-rupture, right, of the sleeve injury, that the posterior aspect of the calcaneus was lifted. So we crossed partially threaded 4/0 cancellous screws with washers and try to close down that fragment. But what we did pay attention to is with that central whip stitches that we threw with the fiber tape, we crossed them around the plantar partially threaded screw running plantar to dorsal, and you'll see that in the next slide. So you can appreciate how it avulsed directly right off the calcaneus. You can kind of see how the bone stock there, when I say that, you know, on the MRI, we see a lot of edema. If you look at that bone, it's all just cancellous bone, and it was really soft. So being able to run those transosseous tunnels, grab those sutures, and then tie off that fiber tape centrally, and then we cinch down the screw and washer, we're able to get pretty good fixation with the ankle joint plantar flexion, obviously in Rob. We can go to the next slide. So this was kind of Dr. Windrum and I kind of looked at it. I was like, okay, well, we really saw poor bone quality in her op. So we got a DEXA scan. Patient followed up with her primary care and was put on a regimen for osteoporosis with calcium, vitamin D, and anti-resorptive medication, some biphosphonate. And then 3 weeks post-op, the incision laceration site healed uneventfully. We were worried because there was a transverse laceration from the whip of the Achilles tendon, because remember that it was being held down initially with a peak anchor as well. So whenever that snapped, it just whipped up. So you had that vertical, that transverse laceration, but it all healed, even though it was like a cruciate type opening, it healed with no problem. And we did serial cast changes, obviously from plantar flexion to neutral, and we're able to put in a heel lift and get her walking in the cam boot by the 8th or 9th week. Formal physical therapy, most likely, it looked like it started around the 12-week time, trying to get her transition to a sneaker while she was in physical therapy. And then at 18 weeks, we had her walking. We kind of took it slow with the post-operative protocol as well. When you have these kind of avulsion injuries, you have to appreciate that bone stock not being adequate. A lot of transformation of remodeling has to take place at a bone tendon interface. So we weren't really aggressive and getting her, all right, we need to move. We just wanted to get this healed. And we did some point, got her weight bearing just to have that motion at home. We didn't want her to lose anything. And then we recently saw her in March, her last follow-up, and she was back to activities, normal living, no complications.
Wow, that was a great case. I think there's I want to show this slide again because there was a lot going on.
Yeah.
Dr. Cottam had asked, where were the sutures anchored, tied planarly or on bone or on skin? So could you maybe go through this one more time? Like where did you tie those sutures?
So the two from the Krakow that are running in the transosseous tunnels, those were tied planarly in front of where you could say anterior to the plantar screw. They were tied off.
Anterior and inferior, correct?
Mm-hmm.
Okay.
And
Oops.
then, yeah.
And then the fiber tapes are to that screw.
Yeah, so the fiber tapes, once we tied the transosseous, the Krakow stitch to the transosseous tunnel, we were able to grab the fiber tape and loop it around the washer and then cinch down the screw and kind of hold that in place, and we cut off the overhanging fiber tape.
That's good. Jamie, could you ask your last question, please? Because you might be able to better articulate that.
I was just curious, to be a great case for like a distal biceps repair tension slide type thing, coracle button. Inferiorly within the calcaneus, you could have avoided the drill holes through the calcaneus with that. Did you guys?
Absolutely. And to be honest with you, Dr. Cottam, I had no idea about that technique, and I really think that you're saying that would have been a great plan to even do that initially as well. Agreed.
That was a pretty ingenious case. So good job, you guys. Are there any other questions regarding this? Yeah, these are tough. These are tough. Great job, you guys. Thank you. Next, we have Dr. Alta Peter. Did I pronounce that correct? Joseph, are you on? I hope, or Dr. Lamb? Hello. Okay, they might not be on. I'm gonna skip ahead if they're not on. Last chance. Okay, I'm gonna skip ahead until they can come back on. Next is Dr. Adam Perler. Are you on, Adam?
I am on.
Dr. Perler might have a little sore throat, so bear with him with his voice.
Thanks, everybody. So the case that I'm going to present is the other Charcot. So it's kind of the variety that we've had tonight has actually been quite good. So we're going to go from the flat foot to the other Charcot. I really liked this slide when I came across this, but the symptoms are in reality nothing more than a cry from suffering organs. And these CMT patients are always really unique challenges, and there's not a lot of people that have expertise in this area. There's a handful of places in the CMT crowd is kind of in the muscular dystrophy crowd, and they're always seeking out places to go for treatment where people are familiar with their deformities. But I've never really seen a CMT case the same. They all have very, very different qualities and different presentations. Next slide. So this patient, it says painful bunion, but ignore that. This was a 46-year-old female that presented with a severe ankle instability. She had lateral column overloading, painful forefoot, hammer toes, bilateral, worse on the right side. At the age of 1.5 years old, she was diagnosed by her pediatrician as having a CMT, and her parents were told that she would never really be able to ice skate, rollerblade, run, ride bikes, or keep up with other kids, and that was not the case. She had a whole lifetime of just being very, very active. She was treated for knee arthritis at the age of 16 in Maryland, and then offered a brace, but didn't want to wear it because she was a runner and she was committed to never depending on crutches. And then at the age of 39, she twisted her ankle coming down the stairs while she was holding her baby, and thankfully the baby was okay. But ever since that injury, her ankle never really recovered. And it's not that her ankle was any more deformed. It's just, I think that was the tipping point for her to seek out options. And this is like I said, a very active young mother. When she came in, I really couldn't believe how she'd gotten through 39 years of life with her ankles the way they were. So the other thing is that she just said, whatever you do to me, I do not want ankle fusions. So that was a big thing for her. So this is her right foot. She cannot really fit into regular shoes, so she's pretty much a flip-flop girl. And you can see just how twisted the foot is. And it's both sides. Both sides are exactly the same, just severely varused, almost like an adult club foot in a sense. Next slide. And so, she set the ground rules right away. She said, I do not want an ankle fusion. So you can click there and I'll go to the next thing. So she didn't want an ankle fusion. She actually, for CMT, this was a rarity for me because usually CMT patients have a wicked drop foot. And she actually had really, really strong dorsiflexion strength, which was a little bit puzzling because I haven't really seen that when somebody's got CMT this bad. Go ahead. And it'd be, this became increasingly painful, and her, excuse me, her whole goal was to be able to walk Disney with her kids. And she had already tried basically bracing therapy and NSAIDs. They'd all failed at this point, and she was coming in saying, I don't care how long it takes. I just want to get this fixed, and I want to be able to bend my ankle. So next slide. And this is what her ankle looked like. So you can look at the far left, that's her ankle in a natural position. Her talus actually looked very flat to me, but I think it's presenting that way because of the way it's tilted in the ankle joint mortise. And then on the right side of the screen, you see kind of the natural position of her ankle, and then I actually tried to pull her heel from underneath her and tried to pull it into valgus, and we did an x-ray on the far right showing that I could somewhat relocate this ankle and get it semi-congruent. And if you look at her distal tibial plafond, it's actually not normal. It's kind of in a varus angulation as well. So there's a lot going on with this patient. And I knew that this was going to be a big challenge, and you can go ahead and forward. So I'm going to make a little bit more interactive as we go. So my question to the fellows, what would you guys do? How would you approach this? What would you be thinking?
Yeah.
Anybody want to stab?
Was there any for her, any Coleman block done?
No, I did not do that. Excuse me. No, she was what I got on the far right was just trying to pull her ankle underneath her. But no, I didn't do a Coleman. I don't know that it would have changed because of how much varus deformity at the ankle itself.
Yeah.
So what would you guys be thinking? What if this, you guys are all, 4 months out from real practice. If this patient came in to see you, how would you be approaching this? What would your thoughts, what would your, would you want to do any advanced studies? How would you approach it?
Hey, Dr. Perler, Danny here. I think I would, try to work up as best as I could. I think the first thing I would do is, I don't know if she has a neurologist where she's living now. I know you said in Arizona she was diagnosed as a kid, but I would maybe see if I can get her in with a neurologist, if not already, and repeat some of the NCV EMG studies, because the fact that she has such strong dorsiflexion could always be, maybe something, maybe somewhat of a misdiagnosis when she was younger or something like that. Regardless, surgically speaking, I think I would, being 4 months from practice, I would probably try to get as many consoles as I could in. But I think from a surgical standpoint, I would likely lean towards an ankle fusion here. It might be less than ideal, but I don't know. That's kind of where my head's at. I don't have any calc axial views, but from the lateral, it doesn't look like there's a whole lot of hindfoot deformity, other than maybe some STJ arthritis.
There was definitely the calc was severely inverted.
Okay.
Yeah. Yeah. Any other thoughts?
Did you say that you were able to, that she was flexible at all in her rear foot, that you were able to swing her?
Semi-flexible. So what I was demonstrating on the far right was that I could get the ankle semi-congruent. Actually, I mean, it is pretty congruent. The problem is that the plafond is tilted into varus. But I was able to get the ankle congruent. So let me ask this: Would anybody listen to the patient's request for trying to maintain motion at the ankle?
I think knowing CMT and knowing that it's a progressive deformity and that she's really lucky right now that it sounds like it hasn't really hit her anterior compartment, you could take the minimalist approach. I think if she wants something done but doesn't want a fusion, and just kind of go in and, depending on how contracted her Achilles is, do some sort of posterior compartment lengthening, gastroc, TAL. Since she doesn't have any sort of drop foot, anything like that, you could even do just a posterior tibial tendon lengthening, like a TN capsulotomy, and kind of swing laterally and look at doing just like a lateral ankle stabilization, maybe a longus to brevis transfer, trying to still maintain all the function through her ankle, but at least hopefully aligning it better. And then you've got a Dwyer in your back pocket too, that you could always throw in if that heel isn't reducing or getting aligned to the tibia.
I like the way you think. Anybody else want to take a stab?
That's my fellow. Thank you.
Yeah, I completely, this is Bellis here. I completely disagree with the TAL gas. These Aquinas, there's no Aquinas in a cavus foot type, or there's very rarely Aquinas. Most of these are medial, muscular, tendinous contractures, and lateral failure. You definitely need an MRI here to see what kind of lateral tissues you've lost. Medially, you're going to have to release that or do a tendon transfer at the very least. I think you need to stabilize the subtalar joint. I think obviously if the patient wants to save the ankle joint, you definitely got to get everything balanced underneath there. Similar to a flat foot, you fix the subtalar. You're going to have to fuse the subtalar joint, in my opinion, with this case to get the Kites angle and to get the inversion eversion correct. You're going to have to release medially, and you're going to have to strengthen laterally if you're going to give them a chance with an ankle. You can stage it and see how they do with that, and then, but they're going to have to know that they're probably going to need an ankle fusion at some point. The TN sag is not really that bad here, or their TN, not sag, but the TN, there's no DJD there, so there's still motion there. But I think you need MRI, you need to look at the lateral, and I think the EMG NCV is good to tell you what kind of muscle group function is still working. So at least you can tell them where they are right now from a revisional standpoint.
Yeah, so let's go to the next slide real quick. So this is basically the different menu items that I came up with for approaching this particular patient. And this is, kind of what's available whenever you do CMT patients. Some of these we're not necessarily going to apply to this patient depending on, what all approach I decided to go. And I was going to try to avoid the TTC fusion, pantalar fusion. And because I didn't know how she would respond, I wanted to keep the door open for ankle replacement. But in order to do that, I was really worried about the thickness of that talus and the malformation of the talus. So I figured if I fused the subtalar joint and eliminated the talus, that could make it a little bit challenging if I were to stage a total ankle for later, knowing that we can maybe do some sort of custom construct on the talus if we needed to. So if you click one more time, it will show you what I did. So fusion, I held off on ankle replacement, didn't roll it out, but didn't roll it in. And everything in green is what I decided to do. So we had the peroneus longus and brevis transfer, lateral ankle ligament repair. I had her consented for gastroc. Once I got everything corrected, I was going to check it. I didn't end up doing it. Steinler strip wire, calcaneal osteotomy, hips tendon transfer, Jones-Tino suspension, dorsiflexion osteotomy first, Brittlestone Taylor of the toes, and PIPJ fusions of her digits 2 through 4. So go ahead and go to the next slide. So that's where we started. And then this is where we ended up. And during the surgery, I was really, really excited about the foot position. Actually, when her family saw the picture of the bottom of her foot, they immediately burst into tears. They hadn't seen their daughter's foot look like that in a long time. So we'll go to the next slide. And post-operatively, it was okay. I look back at this, and I have not done any Z calcaneal osteotomies with wedges, but when I look back, I kind of wish I would have. The other thing is I did a closing wedged wire, but I could have also done a lateral shift as well that I didn't do. My goal was to try to get the ankle as congruent as possible, and I felt like we did an okay job of that. Obviously, she still has a really malformed ankle. Next slide. So here she is. It's a lot better, but it's not great. And the residual deformity is not, I couldn't have gotten any more out of the foot unless I went to triple and wedged the triple, or like I said, that the thing I kicked myself on is not doing that Z calcaneus with a lateral based horizontal wedge. And I'd be curious to hear if anybody else has experience with that. But that's where we were with the right side. Next slide. So then the question is, what's next? Obviously, we have the left side going on. So we'll go to the next slide. And this is now after I've completed the left side, very, very similar approach. The feet are better. They fool you though, because as soon as she steps down, she still has that lean. And then we'll go to the next slide. Now, this is a video I wanted to show you how she walks. Now, this is, believe it or not, infinitely better than it used to be for her. It's not great. And that right ankle has definitely started to go back. But when I really look at it, that's actually the ankle joint that's doing that for the most part. Her left foot actually looks pretty good. She's about, we're about 8 or 9 months out from her left side surgery. I did the right side first. And she actually just about 3 weeks ago told me that they went to Universal Studio and they walked all over the place. And she said she did over 10,000 steps. And that was the first time she's done that in almost like 6 or 7 years. So she's happy. It's not perfect. But I will say, when I look at this now, and this is just my opinion, on that right side, I would consider going to an ankle fusion. On the left side, depending on how she does, because people don't do well with bilateral ankle fusions. As well as her left side is holding up, I would consider actually replacing the left side. But I'd be curious to hear what everybody else thought, if anybody would attempt something different or approach this completely differently.
Adam, this is Brad. I think, yeah, really good results. But as you stated, you know, it's still a bit deformity left. I think, you know, my experience is, you know, when I was a fellow under Dr. Paley, he did this procedure where, similar to what you listed, there's kind of a whole list of soft tissue balancing procedures that we would do, including radical plantar fasciectomy, like removing the whole.
Yeah, the Steinler strip-in. Yep.
Yeah, but not just a release. Actually, Tagent, if you look in his pediatric book, it shows the approach of a long linear incision from the ball of the foot all the way to the heel, and removing the entire plantar fascia as one of the deforming forces of this CMT foot deformity. So anyway, long story short is it's not a bony deformity, it's a muscle imbalance. So I think that a lot of these more chronic CMTs, you do have to consider osteotomy, like a Dwyer or slide, or kind of the combo, or sometimes subtalar fusions. I have had to do isolated subtalar fusions to get the heel adequately underneath the tibia. And so soft tissue rebalancing really works, but I don't know if you did a post-tib tendon transfer. That's one of the main staples of the protocol. That
the only reason I did not is is because she wasn't having dorsiflexion weakness. That was on my menu, obviously, for CMT, and that would be what I would normally do. But in her case, she had, you know, really good dorsiflexion strength, and I didn't want to, you know, being that she's relatively young, I didn't want to burn that bridge yet. I think Danny mentioned earlier that these are progressive, and that's, or maybe it wasn't Danny, but you know, these are progressive, and that's something to take into consideration. You know, I think when I talked to her about it, it was, you know, we're going to do this for now. Less is more sometimes. We have not burnt a single bridge with what we've done. You know, the next step would probably include further stabilization of the hind foot, maybe fusion, like you were mentioning. I'm just kind of curious to see if anybody in this particular case would consider a TAR. She understands perfectly that it's a risk, you know, and that CMT or any neuromuscular disorder with a TAR is a relative contraindication. It's not absolute, but she doesn't have numbness. She, you know, she has control over foot for the most part. It's just medial to lateral, but I could really argue on that right side, the reason we're leaning so much is because of the abnormal tibial plafond position. So that would be another option, would be maybe to do some leveling of that tibial plafond.
Yeah, so Adam, I think, you know, the foot is not balanced yet. That would be my criticism, that you still have varus in the foot. And yeah, the ankle is varus as well. But I'm not sure that the foot's fully balanced, that if you put a total ankle, it's going to still rock unless you, you know, balance the entire foot.
I don't think I would consider a total ankle on that right side. That left side, to me, is a lot better balanced. And, you know, to me, it's going to be what happens in the next year or two. Right now, her ankles aren't bothering her enough to do anything. Because I do feel like I could even that left side out better, you know, because the foot is relatively rectus. But that right side, you're right, it's the balance is still off on that right side. And she knows that we might have to fine tune that. The other thought, you know, I mean, the peroneal tendons, obviously this is a peroneal tendon overdrive on the longus, and the brevis is basically just not doing its job. So that's why you do the FDL, or sorry, the longus to brevis transfer. I read a while ago about possibly doing an FHL tendon transfer to augment the peroneal tendons. Has anybody read that or experienced that or used that technique?
Yeah, we've used it.
Did it work?
It works it's more of a static stabilizer. It doesn't have a lot of dynamic motion.
Oh, he's there.
But I would say that number one, my quick comments about your correction is number one, you need when you do a Dwyer, you got to really do it aggressively. Number two is you have the PT tendon is always going to overpower perineals no matter even if you combine them together. And you know, and you're right, that ankle is really deformed and it's got used to being varus. So you almost have to overcorrect your foot in order to compensate for the deformity at the ankle joint. So that's tough. And the only thing I can only say is that if you're ever going to consider an ankle implant, you have to validate with EMG that you at least have some decent neuromuscular function of some of the opposing muscles in the leg. Guys, can you put it on mute if you're not speaking?
I am.
Okay, that was a tough case.
Yeah, it's a tough case, and I think her foot's going to kind of let me know what needs to happen next, and it's going to really be based on symptoms. So right now she's very happy. I'm not happy with it. You know, I'm a perfectionist, so I want that foot to be really straight. But I think I don't know that I could have pushed it any straighter without compromising the ankle because that plafond is so tilted. So that might be another consideration at some point is if I go subtalar joint fusion, potentially simultaneously try to level out that talus on the top side, but in order to do that, I would also have to level out the tibia along with it because they can be congruent, and when they're congruent, there's actually a decent joint there. So that might be a way to avoid fusion or replacement, at least until she gets to a later age.
Yeah, Adam, real quick, the other two things is that some of these patients have rotational deformities. So you might want to get a rotation profile CT because that may be the external tibial torsion might be killing you. And also you could consider a supramolar osteotomy, and that would not only bring the foot flatter, but it would also straighten out the ankle as well.
Yeah, that's what I was thinking on that right side to level out that tibial plafond in addition to maybe doing a subtalar joint fusion and get it out of the varus that way. That might give her a lasting result and still preserve her natural ankle.
Good case. Those are tough. All right, I think I think that was the end of it. At the risk of running a little later, I think that's everybody's report here. So thank you guys. I appreciate everybody's participation and listening through these. This was kind of a little bit of a last minute change of type of venue that we're having, but we appreciate all the fellowships for presenting. One of our fellowships was, unfortunately, we were not unable to present, but maybe we'll give them an opportunity at a later time or date to present their cases. But if there's no other questions, does anybody have any last minute questions or any other fellowship directors want to say anything? No, we're good.
Yeah, this was a lot of fun tonight.
Yeah.
I look forward to doing more of these interactive ones.
Great. And keep up with our next meeting. I'm not sure, was it next, that's second to last Thursday of the month, next month?
I believe that's correct.
Yeah, so keep an eye out for your emails to get those invitations, and please log on to the FPMA fellowship website to access this recording if you ever want to listen back to it and to some of our other webinars. So we appreciate you all listening in on this, and we'll wish you a good night. Thank you.